Wonderful. So what I want to do for you is to kind of do a brief survey about what we know about mental health in young adulthood. And fortunately, I think it was Dr. Steinberg that said early on today that, in terms of psychological development, there just isn't a lot of research. So it's actually very easy to cover this in a short period of time. And the same applies in terms of what we know about mental disorders as well. So this gave me a great opportunity to kind of run back to some data that we have and to kind of dig into it a little bit to see if we can kind of learn a little bit more about what's going on during this particular transitional period. Okay. So first off, all the work I'm going to be presenting has been funded by the National Institutes of Health or other foundations. The big gap in terms of answering the questions about the magnitude of the problem of mental health issues in young adulthood is that in order to get good estimates of these problems, you have to go out into the community and you have to collect a representative sample and to do very intensive sort of psychiatric interviews, often with the child themselves and sometimes with their parent. And then if you really want to get information that's going to be most useful for intervention and for risk and resilience models, you also need to follow these folks over time, so that you can kind of track them into young adulthood and then kind of track them on into young adulthood as well, into adulthood. And I've been fortunate to work with a study that's followed a sample of 1,400 kids for 20 years from childhood now into their 30s, so we can address some of these questions. But I just want to focus on giving you a topography of what's going on with mental illness. So there's a couple simple questions to answer. Just how common are mental illnesses in this age group? How do these types of illnesses affect functioning? How did these kids get there? What did they look like before in development? And then lastly, what happens to them? How do they get help? What happens with this service system that we've already heard is fragmented and seems rife for the potential for people to fall through the cracks? So if nothing else, how common is mental illness in this age group? If you look across any sort of a 3-month period, what we see is about 20% of kids in this period meet criteria for a well-defined psychiatric disorder. And of those, about half of them meet criteria for 2 or more disorders. And the most commonly occurring pattern that we see there are kids that have both an emotional disorder, either depression or anxiety, plus a substance disorder. And so that's obviously a target group that we really want to focus on. Question is, how does this compare to other points in development? 20% actually sounds like a lot. And if you can see the red line better than I can, what it should show is that actually this is different than we see in the rest of development. So if you look on the left side of the white line, we have childhood and adolescence. And the rates of the 3-month rate of having a disorder there is about 10%. Maybe a little bit less at some points, a little bit more at some points. But then you should see a dramatic jump as it kind of crosses the line to 1921 and then out into the 20s. So we see about a doubling in the 3-month rate of disorders. And as you might guess, a lot of this has to do with the emergence of substance disorders, alcohol abuse dependence, cannabis abuse dependence, such that if you were to actually remove those disorders and to look at the same age curve, what you would see is that the rate doesn't appear to change a whole lot. That's not to say, though, that there aren't still significant changes even in the non-substance related disorders. So that says at any one point in time, about 1 in 5 young adults are going to be dealing with one of these problems. What does that mean in terms of how many kids have been exposed at some point in development? It's a different question. How many kids have had a cumulative exposure to some sort of a psychiatric problem by the time they reach what we call adulthood? And what we see here is that's just the prevalence line. But if you add up these cases over time, it's not necessarily the same people at each point in time. There's different people coming online with disorders, and then there's other people that are obviously recovering, such that by the time we reach age 25, 60%, over 60% of kids or young adults will have had some sort of well-defined psychiatric disorder. So what I'm saying is it's normative for young adults to have had an experience with mental illness. Now, if you add on to this folks that had some sort of psychiatric symptoms plus impairment, but let's say it just fell below our threshold for what constitutes a disorder. and you were to add those on top of this, we would see that about 80%, 80+% of kids have been affected by psychiatric distress in some point in development. So what I'm proposing is that dealing with some sort of mental health issue across development is actually pretty normative. And as we can see, a lot of this is going on in the young adult period. So that's something that we need to think about with the kids that we're seeing. Okay, so I told you that that it looks like we have changes across development for different disorder groups. And it's actually distinctive for each of the different groups that we look at. So first, this is the age curve for anxiety disorders. And you can see a peak early in development when we have something called separation anxiety disorder, which is relatively common. And then you can see it kind of falls off a bit during childhood and adolescence. And then it starts to rise into young adulthood. And most of that increase is particularly attributable to two disorders, generalized anxiety plus panic disorder as well. The rates of panic disorder seem to be going up very dramatically, 19, 21, and then they actually are still rising at 24, 25. We're now interviewing these folks at age 30, and we're looking to see whether these rates have leveled off at this point or not. The next group are folks that have depression. Here you can see that the major change in the prevalence of depression actually occurs earlier in development at puberty. And that's where we see an increase in the rates of depression, particularly in the case of girls. That sex-specific difference with girls having higher rates continues on into young adulthood. And then in childhood, we have all these disruptive behavior disorders, ADHD, conduct disorder, and oppositional defiant disorder. And because of the way we define these disorders, they disappear once you get to young adulthood. I don't think these folks disappear. I think there's another system that they move into. But the disorders that we looked at in childhood do. And then, of course, we've got two other groups. This is the alcohol abuse independence and then cannabis abuse and dependence. And I think you should be getting very used to seeing that spike. We've seen that a few times here. But one thing to point out here is we can already see that spike coming down a fair bit at 25, 26. This is something that we talked about seeing in a number of different data sets. These folks just passed through young adulthood. So this would not necessarily suggest that it's kind of moving this curve up in development. Okay? So we know a little bit about how common this is. The question is, what do these folks look like apart from the fact that we know that they have a disorder? So in order to answer that question, we came up with a number of different scales of functioning to kind of give us a sense of what's their kind of profile of real-world functioning. And the four scales that we put together were one that was related to physical health and had a number of different indicators of their physical health during young adulthood. Second was risky behavior and criminal behavior. This is not a complete list of all the indicators. The third one was related to educational and employment outcomes, and finally we had a scale related to social outcomes. And we combined these indicators into scales and then standardized them so that we could make comparisons across groups. And what we did is compared three groups. Folks that did not have any sort of psychiatric disorder in young adulthood to those that had a non-substance related psychiatric disorder to those that had a substance related disorder. And what we see is that the higher scores, the scores above 0 for the standardized units, mean kind of less problems across these scales. And you can see that the folks without a disorder are doing best across the board. That's not a surprise at all. We can see both of the diagnostic groups showing a fair bit of challenge in each of these different life domains, with the non-substance group having the more impairments across most of these domains, except for the riskier criminal behavior. And that's obviously the relation between substance use and criminality. But you can see the problems that we're seeing across all of these groups. And just a few examples of this. Young adults with a disorder were twice as likely to report regular smoking, which we know is associated with all sorts of outcomes down the road. 4 times as likely to report police contact. Twice as likely to have been fired already. 3 times as likely to have defaulted on a financial obligation. 4 times as likely to be in a violent relationship. These things should kind of These things don't necessarily all fit together, but I think what they begin to show you is that there's a profile, and these problems affect many different areas of functioning and make it really difficult to achieve some of those milestones that we've talked about earlier on about, getting the steady job and about, finding a steady relationship and so on and so forth, and really may impede the person's ability to get to that point for some period of time. So the next question is, how did these folks get here? And so this pie chart here shows all the folks that had a disorder in young adulthood, and it's basically looking back at what we knew about them in childhood. And what we see is that the largest slice of the pie here is the 53% that had some sort of a psychiatric disorder in childhood. So this is suggesting that there's substantial continuity in these disorders over time. There's another 24% of them that in childhood had a subclinical problem. So that's a full 75% of young adults with a disorder where there was some evidence of struggle earlier on in development. This is strong evidence for continuity of these psychiatric problems. And when we actually look at the culprit, and this list here is just a list of different childhood disorders and looking at the difference in the rates between folks that have an adult disorder versus those that don't, we see that there's many contenders. They had elevated rates of substance disorders, not quite as much with ADHD, but then ODD is oppositional defiant disorder, conduct disorder, depression, and anxiety. And when you try to parse it down more specifically than that, there still seems to be a lot of evidence that the patterns that we see of prediction from childhood to young adulthood are not necessarily always the same disorder predicting itself over time. So this isn't just a case where depression in childhood predicts depression in young adulthood. It's anxiety predicting later depression, depression predicting later anxiety, conduct disorder predicting later depression, so on and so forth. So I'm going to skip the next slide so that I can get to a really important part of this. So as part of these interviews, we asked about these different disorders, and then we also asked about different service utilization in 39 different areas where they might have received services. And we wanted to kind of do a comparison to see whether you can actually notice a difference between what's going on in childhood and what we see here in young adulthood. And so these are that's just the base rate, the yellow line, of service use across childhood, adolescence, and young adulthood. And you can see the rates are higher in childhood and adolescence, and then they fall off just a little bit. But what we're really interested in are the conditional rates. That is, for people that actually had a disorder, what were their rates of service use, okay? And here, it's slightly different. We see a kind of more dramatic pattern where about 40 to 50% of children or adolescents that had a disorder got some kind of service in some kind of setting. When we get to young adulthood, it drops in half, so it's about 25%. 1 in 4 folks with a diagnosis get any help at all. And that's not even necessarily saying that they get the optimal care or something that's efficacious, right? So what's the culprit? Where are they missing out on the services? So this looks at the conditional rates by different service sectors. And we can see that if we look at specialty psychiatric services, here's one area where we see a drop from about 19% to about 10% in young adulthood. So this is one area where they're getting less services, and this is also one area where they're most likely to receive efficacious services. Less of a drop in terms of general medical services, but then the really dramatic comparison is for those that they receive in the educational or job setting, okay? So the most common place that kids and adolescents receive services is at school, okay? It's not necessarily always the most effective place, but it is a nice safety net for getting a lot of folks in with a range of different problems. But in young adulthood, we see this completely drop off to basically a vanishingly low rate. And so that safety net is no longer there for them. And very few people are reporting receiving services either at college, university, or in the community, okay? And then finally, the other area where we see a significant drop is in formal services. And what's really interesting about this is isn't contingent upon insurance status. Informal services can include things like an AA group, or visiting a spiritual advisor, or working with a mentor, big brother, or so on and so forth. So you don't necessarily need to be able to bill that to someone to receive that service, and we still see this falling off. So what this may suggest is part of what we're seeing maybe here has to do with healthcare access. Part of what we see here is just a service access which is disappearing. And then in terms of informal services, this may be the young adults actually deciding that, that this is less of a priority for them. The other obvious explanation here is that they're transitioning out of the home in some cases, and so one of the most common ways that kids show up and adolescents show up in service settings is parents pushing them. Okay, we don't get many kids that walk in the door and say, "I really need services now," and that's what we're relying upon them to do in young adulthood, right? So is it any surprise that we see this drop? And actually, that's one reason to not be as down about the fact that a lot of these kids are living with their parents into young adulthood. Maybe this is an opportunity for someone who's monitoring them and in close contact with them, and maybe has a little power or authority because they hold the purse strings to put some pressure on them if they're dealing with a problem. Okay, so the red light is beeping. So I just want to kind of end with a very simple conclusion based upon this early look at what we're seeing in terms of what's going on with mental health. We're seeing the rates increase dramatically as compared to childhood and adolescence, and we're seeing a change in the constellation of challenges and the constellation of disorders that this group is dealing with as compared to folks earlier in development, and also as compared to with folks down the road, because you saw those substance abuse rates already fall off. Okay? We've already seen that this is affecting a number of areas of their functioning, their ability to function at work, socially, their likelihood of having criminal contact, so on and so forth. And so this is a group that we absolutely need to prioritize. And what we're seeing is that this is a group that's least likely to actually show up in a service setting to receive any kind of help at all. So it's not too much to say that these folks are falling off a bit of a cliff as they enter young adulthood in terms of service access. And I think this is enough of a public policy priority, so I'll just leave it there.